I guess with Australian audiences, and no doubt there are other people going to watch this as well, with anything that's new to us, we're pretty keen to find out what sort of basis I find both clinically as well as research. Because I mean, you could look at the Mulligan model where Brian Mulligan's come across some fantastic techniques that are hugely applicable in a clinical caseload. And say 10 years ago, there was very little research looking at it from a physiological basis, but a bit more on the clinical side. And I guess it's the same thing with Luigi Stecco's work, is that it's new to us, so people would be asking the questions like what evidence, what research, what anatomical studies. Just can you just point us in the direction of probably three or four things that you have become aware of that you think would be of relevant to people considering and understanding what the efficacy is behind the Stecco method?
Sure. Yes, well, now we have to keep in mind that Luigi Stecco initially was working very much on his own. He's very much a thinker, curious thinker type of person who still today he continues working. He studies in the morning and treats his patients in the afternoon. Now he's been doing that for over 40 years. And so he developed his model, and he did quite a lot of animal dissections because he didn't have access to human cadavers to be able to look at his anatomical ideas, if you like. Fortunately, as he was developing his model, he was also growing up two lovely children who are now adults. And Professor Carla Stecco is a professor of anatomy at the Padova University in Italy. She is trained as an orthopedic surgeon and then opted to go into anatomical research. Her brother, Antonio, is a physiatrist, so specialized in physical medicine and rehabilitation. He is occupying himself with research more into the clinical aspect of the method. So if we now do a search on PubMed using the terms Stecco, fascia, you'll come up with about 60 papers. But if you do a search just with Stecco, you'll come up with much more, because a lot of the initial research was what I call background research. When Carla Stecco started investigating her father's ideas, and I often say that Carla probably started because she was just sick of Dad talking about
At the kitchen table.
and possibly wanted to say, Dad, you've got it all wrong. But what she actually found was that Dad did get it right in quite a lot of aspects. So when she first started, she only found, and one of the first things, that I was going to say she was going to look into was the innervation. Obviously, if we're talking about fascia being an active part of musculoskeletal activity, it has to also be an innervated tissue. When she looked into that in literature, first of all, she only found two papers, one by Yaya that said, yes, it is innervated, and the other paper, can't quite remember the name now, but said, no, it's not. So she went and looked at the innervation, first of all, and she demonstrated that deep fascia is well innervated with free nerve endings, Pacini and Ruffini corpuscles. So that was, the very first step to take. We're dealing with an innervated tissue. It's not just a packing tissue. It's not just a tissue that surrounds. It's certainly not just the white stuff that we have to get rid of to get down to the real things. The other thing that Carla Stecco came across and has now published a number of papers about is the fact that deep fascia is not a disorganized, irregular tissue, as is often been claimed in anatomical texts. It is a very well-organized tissue, multi-layered collagen fiber bundles. Each layer of collagen fiber bundles is separated from the next by loose connective tissue, which makes a little bit of interlayer sliding possible. The collagen fibers in each layer are aligned in a different direction, which gives us type of a poneurotic type structure. Really interestingly is that the angle between the collagen fiber layers has been measured in both crural fascia, thoracolumbar fascia, brachial fascia. It's always approximately 80 degrees.
Okay.
Now, this type of multi-layer structure permits a certain amount of stretch and a little bit of recoil, and it means that every time we move, our deep fascia is being stretched and pulled. Now, if that's an innervated tissue, and the innervation is mostly of a proprioceptive type, it's giving us continuous information about where we are in space, if we're on target with our movements, are we achieving what we want to achieve, etc. What else did they look at? The other thing I think that was important that the Steccos demonstrated from an anatomical point of view was that there are these myofascial expansions that connect segments of the body together. So while we know that biarticular muscle fibers connect two segments together, just by the name biarticular, there are also important myofascial expansions that exist in everybody that connect the various parts of our deep fascia together to form a continuum. And it's the anatomical substratum or underlying anatomical basis for the myofascial sequences. From a clinical point of view, those were the key points about the background research. They first had to demonstrate it was an innervated tissue. They first had to demonstrate that it existed because some anatomists actually criticize them, saying, well, fascia doesn't really exist. They first had to demonstrate that it was capable of transmitting tension, so they had to do a lot of background research. In terms of clinical research, we've looked at chronic shoulder pain, patellar tendinopathy, subacute whiplash disorders, chronic pain in post-ankle sequels, aspecific low back pain, using the method in hip replacement rehab programs, carpal tunnel syndrome, TMJ joint pain. So we're getting there in terms of clinical studies. There are lots of different studies that are ongoing. As you know, it's not that easy to publish.
No, not if you have a new method which, yeah. But just backing up on one thing that I just suddenly thought of.
Yeah.
You mentioned, well, one of the things we're told is that the human skin, the surface area of the human skin is the largest organ in the body. I'm just wondering if you think about the massive amount of deep tissue, the surrounding fascia of muscle tissue, the bonding, the blending, the poneurotic attachment to periosteum and the periosteum itself. Has Luigi or Carlo actually tried to calculate the approximate surface area of the fascia in the human person, given that it is so highly innervated and obviously so important in a proprioceptive role?
No, I don't think they're actually trying to calculate the surface area as such. No.
I'm just wondering if we have a bigger organ in the body than the skin now.
Yeah. Well, I don't know if it's bigger, but certainly it's made up of different layers. I think that I certainly think that Carlo Stecco is, right up the top there in terms of understanding fascial anatomy. I live in the same town that she works in, and in the anatomy department of Padova University. She's certainly got a good team of people working on studies. So their latest studies, for example, are dealing with the possible role of endocannabinoid receptors within fascial tissues. Could it be that when we're working on these points, we're triggering some type of reaction within the endocannabinoid system?
Sorry, what are the
They look.
endocannabinoids for a newbie like me?
Well, they're the receptors that we have within lots of different tissues that when they're stimulated, then they are they can reduce sensitivity of nociceptors.
Okay.
Okay, so fibroblasts are so it's to do with pain management. So so they're looking at the histology of fascia in great detail, let's say. She's also working with the biomechanics of fascia, so how it responds to stretch, its viscoelastic properties. Obviously, they're looking into they've certainly well researched the anatomical connections at this stage, and I would just point out that she's published a very beautiful fascial anatomy atlas, which came out at the end of 2014, which has some fantastic photographs if people are interested in fascial anatomy. I've spoken to you about this before, Doug, but I think that all physiotherapists need to know about fascial anatomy. It's a tissue that has been ignored for such a long time, and it's always been there. So
Even when we did our dissections, the thing that we were basically dissecting away was the fascia, and you used to curse the stuff because you had to trim it away so meticulously and get to the muscle or the bone to expose the joint or whatever it is that you were particularly. And I remember doing a serial dissection of an ankle, and the fascia was just so tightly bound, and it just went over my head that if it's tightly bound, there must be a functional reason for it to be like that. Our body does respond to its environment, and there's a reason the tissue is like that. And it went completely over my head. Being Maitland trained, I was looking at the joint. Coming from Canada, I was interested in the muscles, but at no point did I really consider what would be the significance of all this tissue that I was depositing in my little refuse tray on the side of the ankle. So you're right, we don't think or haven't thought of the fascia. So on that sort of point, there are other people who talk about fascia, like Thomas Myers with his anatomy trains and the myofascial release techniques by Barnes. Is there a way in which you could clarify perhaps what the Stecco method is offering that is perhaps different or the same to those types of otherwise known myofascial techniques?
right, I've asked Luigi Stecco because it is a question that I get a lot in courses. What's the difference between Tom Myers' anatomy trains and fascial manipulation? And I like Luigi's response because he said just tell them that they're similar concepts that have been developed in complete autonomy. So they didn't have any contact with each other prior to Tom's first book. I think it was published in 2002. But at that stage, Stecco had already published in Italian 4 or 5 books about his ideas. And so I think it's a case of, sort of great thinkers come up with similar ideas. They've met several times and have shared their ideas, and conferences. I know that Tom and Carla are always discussing things together. So it's interesting. In terms of physiotherapists, I think the Stecco method gives us a step-by-step analytical type approach. And we have extensive anatomical studies that back it up. And as we said before, it has that similar type of layout that physiotherapists are used to with our subjective examination, objective examination, test, treat, and retest type of procedure. As far as myofascial release by bands, as far as I know, it has more of a series of protocol approaches. Okay, and so compared to the Stecco method, I think we're talking about with Stecco, it's a very personalized analysis for each patient, and we take into consideration things like symptoms, presenting symptoms, of course, concomitant pain, previous dysfunctions, and trauma that have happened in the past. We have to develop an hypothesis for each patient. We use that biomechanical model as a framework. I guess we can say, as compared to the myofascial release, that we're dealing with a more type of scientific approach and less of an intuitive type of hands-on, having to feel where tissue is pulling or not pulling. We kind of go through an analytical process right back in the beginning of trying to get this work out there and get it communicated. I think in 2009 we were setting up a workshop in an international conference, and Carla said to me, "What are we going to call the workshop?" And I said, "Oh, I don't know. Let's call it the beginner's guide to the dummy's guide to the fascial system." And that was just a joke, you see, because it's such a step-by-step fill in the dots type of approach, but of course it's based on anatomy at the same time. It's not much. There's not much. You don't have to think that you have to put your hands on and feel like sensitive fascial pulling, that type of thing, which is some of the fascial techniques out there do require you to have that. You go through an analytical process, and yes, you have to palpate specific points but they have a specific anatomical location.
Okay. Just one last question with regards to the fascial manipulation courses that you'll be conducting here in Australia in 2017. What can participants sort of expect to learn by attending that they would sort of walk away within a week and think that it's improved their clinical efficacy from your experience in teaching other students?
Right. Well, I certainly think that they will work away with a better knowledge of how fascial anatomy is and how the fascial system is organized from a histological point of view, and its connections between the various structures.
Which, to be honest, I mean, that's something we just don't know. So that's a pretty big groundbreaking thing as well. It's sort of saying, like, you walk away knowing the muscles of the human body. It's a pretty massive thing to start with, isn't it?
Yeah, in fact, but I'm fairly confident that they'll be getting a really good updated evidence-based information because of the type of work that the Steccos are doing in the anatomical research. Having said that, they'll learn the step-by-step model, and that then simplifies the analysis of fascial dysfunction. While when we look into fascial anatomy, we realize that it is incredibly complex. And as you've seen yourself, when you do fresh cadaver dissections, the thing that we keep asking ourselves is, how did they manage to think that this tissue was not doing something in our body? How did they manage to even imagine that it did not have any particular role rather than just filling in the spaces and keeping other things in place? This is what I was told when I studied anatomy X amount of years ago.
And probably still being told now, I think, too.
Unfortunately, yes. So they learn the step-by-step model. They can analyze the fascial dysfunctions. I do like to point out that while they use the specific assessment chart that has been developed for this method, it does have a subjective and objective examination that is not that different from what physiotherapists already do. But I like to underline the fact that participants are learning a new way to analyze musculoskeletal problems, but they don't have to forget anything they already know.
Yeah, so they can still integrate it.
Exactly. We have people doing our courses, not only physiotherapists, and this has been a specific mandate from Luigi Stecco. So we have a wide variety of people coming to our courses, some of them with over 20, 30 years of experience in their field. So with a lot of clinical expertise. Some of them are dry needlers, and they've been able to adapt and integrate this method very easily into their work. It helps them to then understand why perhaps distant areas have to be addressed, and not only or specifically the presenting pain area, and which distant areas and why distant areas in that particular patient need to be addressed. We have people with manual therapy experience, and they find that by shifting their focus perhaps from the joint to the fascia and working perhaps first on the fascia, quite often that what appears to be a limited joint movement frees itself immediately, and it allows you to work at a distance from, say, an inflamed joint, and so you can work even in acute cases without being concerned about working over inflamed tissue.
Just on that, because when I was watching Renee when he was out here doing the one-day workshops, one of the participants had a limited knee-to-wall range, and to all watching it looked quite straightforward that it was either going to be a soleal tightness or he had some sort of joint injury, and I think his injury had actually been 10 or 15 years long standing post a motorbike accident. So to the manual therapist looking at it, you'd be looking at doing some sort of AP glides on the talus to improve his dorsiflexion. Now, to everybody's surprise, Renee was working on, I think it ended up being on some centre of coordination on his inner thigh, and he did 2 or 3 minutes there, and then we reassessed the knee-to-wall range. It was significantly better, and I remember sitting there thinking, there's no way I was going to be, looking towards that in an analysis as being relevant, and that's obviously a limitation on my behalf. I could see the joint could have been involved, but I thought given the duration I probably wouldn't think you'd be much changing. I could see soleus was going to be involved, and that would be something I'd probably look at with some needling work, and then I'd probably be giving a home program. But to see that change within 5 minutes on an injury that had been there for 15 plus years was quite an eye-opener with regards to the potential of, as you say, these areas that are distal to the so-called symptom site.
Exactly, and I think that when people start realizing the complexity of the fascial system and how it's so important for the fascia to be gliding correctly, and I'm talking about both gliding between deep fascia and muscles, but also on an intrafascial aspect, because these collagen fiber layers do have to glide a little bit between themselves, okay? And it's so important for that to be happening in order for us to, say, recruit our muscles efficiently. And so I found that getting to the Stecco work, that before proposing, say, any kind of exercise program, checking these key points on the fascia, I was able to allow the patient to do pain-free exercises, and so that they were able to get on with their exercise program much, much faster. Uh, so extremely useful post knee replacement, hip replacement, a huge type of caseload area that we can cover. If the fascia sliding and gliding correctly, fine, go ahead with your exercise program. But I think that most therapists have found that by checking it first, then their patients are getting on much faster with their exercise programs, for example. Yeah. Uh, mm. And so, yeah, working on a distant segment is fascinating. But once we understand how the myofascial sequences connect together and then not just lines drawn on the body, then we can sort of understand it much better.
Yeah.
Yeah.
Now, just before we close, Julie, I think we should mention that the course is 6 days, the level 1, and it's split into 2 3-day components. 6 days can often seem a lot for the average manual therapist here in Australia who's probably used to no more than a weekend course. What do you want to have to say just briefly about the concept of having the 6 days for your level 1 course?
Well, when I look back at participants' comments, most times or most courses, I find there are a number of people who say that the course content was very full. So yes, it's 6 days, but it's 6 days very full on. There is a lot of information that we try to get through in 6 days. I'd say that most people by the end of the 6 days realize that perhaps they needed a few more days. Uh, um, and just to sorry, so yes, I realize that it's hard to get time off. It's hard to take time away from patients and family, um, but I find that the majority of people don't regret having found out about fascial anatomy. Yes, having learnt a method that they can apply relatively easily, and it kind of makes going back to work even more interesting. And so each patient becomes a even more fascinating story to unravel.
Yeah, and I think that's the bit that sort of keeps me going day to day too, is that if you look at each patient as a bit of a detective case, and your job is to sift through the clues, work out what's relevant, put them together into a sequence, and then bring it back to the person and say, look, this is the story I'm hearing, and from that basis, this is what I suggest that we do. And you're really looking for a much longer term, more broad based approach. And I think that the fascial manipulation as a concept fits into that want to get deeper sort of idea or model really well. And I think, as you say, patients becomes infectious and enthusing because they can see that you are actually applying knowledge, reasoning, logic, and understanding their particular situation, so it's very individualized, and that brings them on board just so much more so than a very simplified recipe type approach to a particular person's problem.
Right. In fact, we often say that fascial manipulation, there's a lot of thinking that goes on. Probably the actual technique and the application of it on these certain points is just the smallest part of the work. A lot of it is sort of hypothesizing, analyzing, and then applying the actual manual technique. Um, Patients, yes, do love it because the whole history, the history becomes relevant, and quite often patients are saying, "Yes, I always thought that old knee, sprain was a part of my back pain, or I always thought I could feel a connection there happening." Um, And then when you're able to say, yes, I think that, perhaps that fracture that you had in your tibia, say 30 years ago, might have then created some lack of gliding in the tissue in that area, and it may be part of what you're presenting with today. They really enjoy it. Yeah. Yeah. And yes. No, you go ahead. Yes, it's
No,
fine.
I was just going to say thanks for that, because 6 days is a commitment to professional development, particularly as you say, for family and friends and husbands and wives and patients as well. But I think at the end of the day, if we continue to reinvent and re-enthuse ourselves, and spend that time educating ourselves how we can improve the next patient that comes through the door, then we feel like we're moving forward, and that's how we help our patients to sort of always continue to challenge ourselves. And fascial manipulation is one of those things that we here in Australia probably are quite naive about, and it's a whole new ball game. And so I think committing yourself to that 6 days split into 2 lots of 3 days is a significant investment, there's no doubt about it. But I think the rewards from the people that I've spoken to that have done the full 6 days, the smile tells it all on their face, and I'm guessing that smile translates into a lot more success with their patients, particularly those patients maybe that they're hitting a bit of a brick wall with. So yeah, thanks very much for spending the time explaining to us here at AOP Education, and I'll put up some details about the upcoming course in March. And if any participants or people that are interested in the course, I'd suggest that they go to our website, have a look at the link, because there's a lot of reference links, there's a couple of video links, and there's some pre-reading that comes out when people sign up for the course. So again, thanks very much from Australia to you for giving us that information. It's really appreciated.
No, it's been a pleasure, and thank you for the opportunity of talking about it. And as you can tell, I can talk about it all day.
Your day is just beginning, so you're all warmed up.
The hardest part for me is to reduce it down into a shorter session, to summarize it. I get enthusiastic about it, and I know that when you start delving into the fascial system, then it opens up lots of other doors and lots of other possibilities in both in treatment and understanding how the human body is working. Yeah. So it's a really exciting area to be involved in, and I love the fact that the tissue has always been there.
Yeah, always so, just under our nose. Or in our case, probably under our thumbs.
Under our thumbs. And another thing that participants often say to me is, and most people are coming with, skill bases already. They say, oh, now I understand why what I was doing was working. And of course, we know that lots and lots of our manual techniques are working. We need to be aware that perhaps when we do put hands on people, we are, working on or affecting also their fascial system. And so it's something that we need to be putting into our professional knowledge base.
All right. Yeah, I couldn't agree more, mate. I always thought when I came back from Canada, having studied there for a couple of years, and I look at my colleagues here that were very Maitland trained in very Maitland thought processes even still then, and they were sort of mobilising C2, 3, and I said, yeah, you're mobilising C2, 3, but what are you touching before you get to it? Because I'd just really come from a bit of a muscular background in Canada, and now I'm thinking about, well, what are you pushing on around the muscles as well? You've got the fascia, so at each level of understanding, you start to realise what you didn't know and what you didn't consider, and how it might be influenced by what you're doing.
Sure, I certainly think that as I've gone on and I just realised that coming into 2017, it's my 40th year as a physiotherapist. I sometimes say to people, I seem to know less as I go on. I realize that I don't know as much as what I thought I did in the beginning. But it's certainly a fascinating area.